everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director of Clinical Education and Partnerships at SICA, where we partner with healthcare providers to offer body composition solutions. I'm so excited today to be joined by Dr. Disha Narang, Endocrinologist and Director of Obesity Medicine at Endeavor Health, and a really refreshing voice out there talking about hormones and obesity care and women's health, men's health. We're going to get into all of that today. I'm so excited that you're with me. Thank you.
Thank you for having me.
So we're kicking off the new year, and I know that we're going to be having lots and lots of conversations around about all of these topics. But for me, the obesity care space and the hormone health space, to put it in a big umbrella term, really have been so filled with both new and exciting information, but also lots of misinformation. And I know sometimes, even as a healthcare provider myself, I find it hard to know whose voices are the evidence-based ones that we want to follow, because some of the prominent voices in this space are maybe not so evidence-based. So I'm very happy that we can kind of jump into that together.
Enough said. Yes, I agree. This is one of my largest populations of patients where women are coming in, midlife, perimenopause, menopause, and just having such a hard time with their weight. And so much of it goes together in terms of how we manage our patients.
So I before we get into the nuanced care, which I know that there will be, I just wanted to see if maybe you could give us a little bit of a maybe kind of overview about how the major metabolic hormones, so estrogen, progesterone, testosterone, thyroid hormones, cortisol, insulin, it's a lot to cover, but sort of how do they interact with body weight and weight regulation, and how do we sort of set the framework to talk about that?
Yeah, a bit of a loaded question, but let's start with the thyroid. So what I will say is that the thyroid gets a lot of undue credit for things it doesn't really do, right? And so what we typically will say is that even if someone's thyroid is completely out of control or the TSH is very high, at best, it might contribute to about 10, 15 pounds weight gain. And so, when people do come in with much more significant weight gain, it's usually not the thyroid. And if the TSH is within range, then adjusting that further is not going to create a significant change in somebody's weight. So what the thyroid hormone does, it does regulate the resting energy expenditure, thermogenesis, lipid carbohydrate, metabolism. If there is someone with hypothyroidism, so again, it's opposite. If the TSH is high, that means that somebody is hypothyroid. If the TSH is low, it means that someone is hyperthyroid. So it's a little bit funny that way. But when someone has hypothyroidism, that means that their metabolic rate is reduced. They may be, having some fluid retention, mild weight gain, again, 10 to 15 pounds at best, maybe an increased LDL, and then they might just feel fatigued and run down. On the opposite side, hyperthyroidism, again, when the TSH is low, people may feel really jittery or in that sort of a buzz, a sort of feeling where you're anxious, jittery, feeling heart palpitations. They might have a little bit of weight loss in that situation as well. And that's where we think about something like Graves' disease, or if you have an overactive nodule, which is called a toxic nodule, or it could be a temporary inflammation of the thyroid called thyroiditis. And so we have to figure out, what's causing a thyroid abnormality, and how do we treat it? Now, moving on to some of the other hormones, and I'll be a little bit more brief about those, but let's talk about
this is great.
Okay. In terms of cortisol, I know cortisol is sort of in the press a lot these days, and social media and everything. True cortisol excess is a very, very rare disease called Cushing's disease. And so again, cortisol these days is getting a lot of undue credit where it doesn't deserve that level of credit either. In the setting of stress, yes, people can have transient elevations of cortisol, which means a temporary elevation, but true cortisol elevations is actually Cushing's disease, which again is extremely rare. I might have seen 2 to 3 cases of actual Cushing's in the last 10 years. That's how rare that is. And so, again, we need to think about that in the right way as well. Again, in this, in the settings of stress and everything, because this is a term that we're hearing a lot on social media these days. And I'm sure, Nina, you have as well. Now, insulin, that's another big hormone, right? Obviously a decrease in insulin. There's different ways to do it. So if the pancreas is not releasing enough insulin, or not making any insulin, that's called type 1 diabetes. So it's insulin deficiency. Type 2 diabetes is insulin resistant. So that means that your pancreas would be producing some insulin, not as much as someone without diabetes, but it's still secreting some insulin. However, your body tissues, your cells are resistant to that insulin. And so that is very much correlated to potentially, how much fat tissue one may have, or adipose tissue. And so this is something that changes a lot with weight gain and loss, even in the setting of perimenopause, menopause, because perimenopause and menopause are a time of increased insulin resistance. And so that very much goes hand in hand, because when someone is in the transitioning into perimenopause and menopause, our level of adiposity is increasing, right? And so that will increase someone's insulin resistance. So when someone is kind of transitioning into that phase, not only do we treat from a weight management standpoint, we treat from, the hormone replacement standpoint as well, because when someone's estrogen is dropping, they're going to start, accumulating some of that visceral adiposity, which is, a lot of women know that as that increased belly fat that we start to see into, 40s and beyond, of course. And so those are some of the big ones. Now, talking about testosterone. So testosterone exists in both men and women. Of course, in men, some men might have a testosterone deficiency earlier in life, and that could be, related to a pituitary issue. It could also be related to a testicular issue. Every endocrine issue, again, because as an endocrinologist, we deal with hormone disorders. It starts with the pituitary. So is there something wrong with the pituitary, which releases all of our releasing hormones? Or is there an issue with the gland itself that's supposed to make the hormone? So if we look at something like, a thyroid disorder, or, a testosterone deficiency, or any of these, endocrine deficiencies, we've got to look at what's the source of that deficiency. So when it's something like testosterone, is it that there's a testicular issue, or is it that, there's a pituitary issue? In women obviously make a much lower amount of testosterone. However, when testosterone is elevated in women, that's also a disorder of something, potentially in the ovaries or adrenal glands. That's more rare, but that can happen. Again, now looking at estrogen and progesterone, this is why we're here today. These are, two of the main hormones in menopause. These are actively shifting when someone is transitioning into menopause. So your estradiol levels will start to decrease, and your testosterone levels don't necessarily increase, but relative to the estradiol levels, the testosterone levels will start to look higher, because this is what's happening to the estradiol, right? And so the testosterone levels start to look higher, and people might start to develop androgenic symptoms. So androgenic symptoms are things like, the hair growth, potential acne, hair loss on the head, those sorts of things. And so, typically for women, increased testosterone can also occur in the setting of PCOS. And so that's very common in our younger women, which could lead to difficulties with weight loss as well, and also fertility difficulties. And so, we obviously manage these things, especially the gonadal hormones, a bit differently in our males and females. But for the rest of our hormones, such as testosterone, our insulin levels, etc., cortisol, all of these are relatively similar between males and females.
Wow. So I love that because, of course, one day long ago I learned about these things, but it's been a while. So I think that was a really good overview, even for some of our clinicians who were listening in. But also the thing that I'm taking the most from that is there is such a, I mean, that is such a medical specialty. There's so much involved there.
Mhm.
There's a lot of, kind of spectrum of, the real high end of something where you're going to see a, deficiency or an excess, right?
Right.
And I think the social media lens that I hear so much about,
Oh
right? It's
yeah.
so simplified, right?
Right.
It's like, let's just balance our hormones. And,
Right. And that
people,
means
there's
nothing
just
to
such
me as an
this,
endocrinologist. Balancing hormones absolutely means nothing to me.
but it's sticky, right? Like people like
Yeah.
these terms and
Right, right.
I mean, this is such our life, right? The things that actually are
Yeah.
clinically important sometimes aren't the ones that hit the internet and people start to pay attention to, but there is a lot
Absolutely.
of talk about the different hormones. So actually, even starting with thyroid and insulin and cortisol, I think that's really helpful because I
Right.
think we hear just a lot of like hormone replacement, and people are saying that without really knowing what it means. So
Exactly, exactly. And this
you
is a
know,
very common complaint that people will come in with, and it's perfectly legitimate, right? I fully hear that patients feel that they have been dismissed for their symptoms. People don't feel good. They want to be able to feel good, and they're trying to reach out to, various avenues where they can understand how to get a better hold of their health and understand what's going on internally. The issue, though, is that there's a lot of marketing to catch people, right? And unfortunately, it's quite deceptive. And so, if someone is advertising that they're going to fix your hormones, I'd run for the hills, right? There's no such thing. There's literally no such thing. And so, what we do though is assess, especially from an endocrine standpoint, we assess: do you have an excess or do you have a deficiency, and how do we get you back to normal? Right. And there are certain signs and symptoms that lead us to checking, certain levels of hormones. And those, that tends to be a pretty thorough overview to determine what we should test. But again, like, it's a very sort of general overview from a social media perspective to say, oh, are you tired? It must be your cortisol. Or, oh, are you tired or, experiencing mood swings? Oh, you got to balance your hormones. It's not that easy, right? It's not that simplistic.
but actually, that brings up a point and a question that I always have too, and I've heard people talk about this on both
Mm-hmm.
sides, is sort of testing or getting lab work drawn to look at hormones, because
Mm-hmm.
we do know that they shift so maybe frequently within the day or the
Right.
week or the month. Is there general guidance on that, or do we really take the person and treat them
Yeah. So
their
in terms
symptoms?
of like hormone testing, I agree. So for example, cortisol has a circadian rhythm to it, right? Even testosterone has a circadian rhythm to it. So the best time to check a blood level of cortisol would be first thing in the morning around 7, 8 a.m. if the person has had a full night's sleep. And so the understanding of cortisol is that circadian rhythm matches, kind of how robust your sleep cycles are. Because if your shift workers have this issue, it's really hard to check serum cortisol levels, and people are shift workers because they're all wacky given their night shifts and, the switching back and forth from the day to the night. So there's other ways to check cortisol via the salivary cortisol, or even a 24-hour urine collection. But we have to be really cognizant of what are we looking for in those tests, because there's a lot of companies now where you can buy an at-home test and check your urine cortisol or your salivary cortisol, and they might sort of run those levels and diagnose you with something that you may not actually have. And so none of those sorts of home tests are validated. There's a lot of false positives, false negatives, and so I would highly recommend, if there's any consideration of abnormal hormone levels or that sort of thing, go to someone that knows what they're doing, and who has training in this, because it's so nuanced. The time of day can affect everything, or the fact that maybe someone has insomnia and they maybe sleep 3 hours a night. Their cortisol levels are going to reflect that inaccuracy. It doesn't mean that they have cortisol excess or insufficiency, but we have to be thinking about it in the context of what we're looking for. And so that is really, really important. And, again, with the thyroid, there's a lot out there as well. Like, oh, we need to check a whole panel of thyroid. Well, there's no indication actually to do that. That's not evidence-based thyroid management. And so we typically, go via the TSH. And then, if that is abnormal, then we move further. But if you have a normal TSH, but then you check something, later on in the day, or maybe you've been sick lately and your T3 level is off or something like that. So checking all this like thyroid panel as actually not something that is widely accepted in the endocrine world. And so again, like, patients may have read online that, oh, we need to check a reverse T3 or we must check your antibodies. That will not change management. Right. And so again, like the thyroid gets a lot of undue credit, and checking extra labs doesn't always mean that we are going to find the answers that we need, or that someone's not necessarily doing a thorough job. Like extra labs doesn't necessarily mean a better level of diagnosis necessarily.
That's important. That's important because there's so many. I mean, there is, I feel like, a very big assumption that the more labs, the more checking, the more data points, the better. And I mean, sometimes we have to put the behavior change lens on too, of like how much can you change given those pieces of information, right? Like you can change medication management, what you're saying, based on a few specific parameters, but if we're talking about what the person can change from a nutrition and exercise and sort of lifestyle perspective, we don't necessarily need hundreds of labs.
And again, like if you're paying hundreds of dollars to get like pages and pages of labs drawn, again, seek a second opinion, because this is not something we often do.
Yeah. And I don't think you covered yet sort of like the progesterone, estrogen, testosterone lab checking, because that's one even, I've, from my medical providers, heard different things.
Right. Yes. So with estradiol and progesterone, again, we need to look. We need to look into what are we actually looking for. So when we do check these primary hormones, like again, estradiol, progesterone, testosterone, etc., we also want to check the pituitary hormones that help make those hormones, right? So it's always in the context of something else. So if someone checks a random testosterone level and it comes down low, well, one, is it first thing in the morning? Because a lot of the time it's checked later in the day, and your testosterone level will be lower later in the day. But also, is it lower because your pituitary is not producing enough LH or FSH? Or is it because it's producing too much LH, FSH, and it's telling the gonadal hormone to stop production, so that's why it's lower. So there's different ways that we interpret that. So we have to look at the releasing hormone, we have to look at the primary hormone that it's releasing, to understand what's going on. Again, the timing matters. In terms of progesterone and estradiol, there's different derivatives of it as well. So there's a 17-hydroxyprogesterone level, for example. We check that often in the setting of PCOS to rule out what's called congenital adrenal hyperplasia. So there's a pathway where there's enzymes that convert precursors into what we see as that primary hormone. And so a lot of the time we are checking those precursors to understand, like, okay, well, if this is high and this is low, is there a problem with the enzyme, or is there an issue with the secreting organ? Or, so it's this pathway that we look at to understand that. So, but in the setting of something like menopause or perimenopause, some people might have an excess level of FSH. Again, this is one of the follicular stimulating hormone. It will be elevated in folks who might be in perimenopause or menopause. However, that's not always the case, but sometimes it could be a good guide to understand, is this person sort of heading into that? Typically, estradiol levels in the setting of perimenopause or menopause will be lower. A lot of the time, though, we don't really check all these hormones when someone is presenting with those symptoms. It's kind of a clinical diagnosis. So, based on sort of what they're presenting with, they might have issues with, they might have developed prediabetes. They might have had weight gain. They might have, increase of like that belly fat. They might be having issues with sleep disturbance, obviously, hot flashes, vaginal dryness, just feeling kind of weak or sore, mood lability. All those things are very sort of, they sound non-specific and they very much could be something else. But when we're kind of looking at that in the context of age, are your periods regular, like all these things, then that's when we start to consider, is this person going to be a good candidate for hormone replacement, so HRT. And it's interesting, and you might be sort of in the same group. Like, there was an entire generation of women, which includes sort of my mom, that wasn't able to take advantage of HRT. And that was because of the Women's Health Initiative study that came out, late 90s, early 2000s, that really scared everybody about sort of the dangers, possible dangers of HRT. And very soon after was pretty much discredited. We've actually seen much more benefit than risk, for people to be on something like HRT. And so what we've seen is actually like protection against breast cancer, as long as you don't have a personal or family history of breast cancer. We've seen protection, cardiovascular protection, protection against colon cancer, all these things, and people just feel better, right? And so we don't necessarily have to sort of suck it up and deal with it, where it's always sort of been this, every single generation of women have had to just sort of deal with feeling terrible. But truthfully, we spend 50% of our lives in menopause. Like, why should we struggle through that, right?
Totally.
And I think that sort of this, like, shoving it under the rug or just toughening up and dealing with it, it doesn't have to be that way. And so I think that these conversations do need to happen, whether it's with your endocrinologist or OBGYN, or whoever is sort of managing your health, that if you are experiencing these symptoms, you don't have to just sit there and deal with it. We have ways of being able to help. And for those who do undergo HRT, typically it's a combination of estradiol. Topical is better than oral. Just the bioavailability is more effective. So you would do potentially like an estradiol patch, and a progesterone a tablet. So that's a oral capsule. You have to take progesterone if you have an intact uterus, but if you have had a hysterectomy, for example, then you could do just fine with the estradiol patch alone. Basically, you don't want unopposed estrogen when you have an intact uterus, because that could increase the risk of uterine cancer. But that's the only reason we use them together when somebody has an intact uterus. And the thing is, like, it could help with some of the fluid retention. It could help with sleep. It could help with hot flashes. All these sort of like vague symptoms that people often present with, but it is not going to cause weight loss. It might make the weight management portion of your care a bit more doable and easier, but HRT is not a weight management substitute.
Right. It's an important distinction too, but also interesting. I think interesting how similar that story you just told about, the study and putting, people not having access and having them suffer through it. It's similar to, what's gone on in obesity care, and really within the past few years, having more options for people. Absolutely. In that, that treatment gap between maybe surgery and lifestyle that had always really not had many options. So I feel like it's a really nice kind of awakening, especially for women who are, both maybe struggling with excess adiposity and going through the menopause transition.
Absolutely.
But also probably tough, because a lot of those symptoms you might hear, especially if someone's lucky to come to you, you have all of that, under one roof. But, you might go to one person and they're looking for these symptoms. Someone else is talking about it in that context. So it's kind of a tough spot, especially if you're not listening to the patient.
There's also still discomfort in the medical community prescribing HRT, right? Because it wasn't talked about for a while because of, again, this Women's Health Initiative study. it ruined it for the team, right? Because there's now misconceptions around it, or there's just lack of familiarity in the medical system around it. And so I do think that, you know, women's health, especially kind of that midlife menopause health, is, we're having a moment right now where more and more people are talking about it, which needed to happen. But there's still a significant amount of discomfort within the medical community in prescribing. And so this is where it's important for you know, patients to become their own best advocate, when, and especially when you are listening to evidence-based information such as us, or you know, a reliable source. But you know, it's important to sort of understand, like, okay, I might be going through this, so then let's reach out to somebody who potentially will listen, and then also consider treating me for it.
Absolutely. I also think, one of the things that's very interesting in this time too is sort of thinking about what is, and I hate to say normal, in air quotes, of course, but like what are these hormone driven body composition shifts that are sort of happening?
Yeah.
What would be considered maybe normal versus when do we get, concerned, and where do we
Right.
start to treat? And then, in the back of my head too is, if we're not monitoring body composition, how do we
Yeah.
really know, other than people saying, oh, I don't like this, where they're sort of
Exactly.
pointing to a specific area on their body.
Right. I mean, so body
Yeah,
composition has become such a helpful tool for us, right? Because before, just like you said, people would say like, "Oh, I have more belly fat," or maybe they're seeing their A1C, you know, transition into a pre-diabetes range. But what's happening is that with that decline in estradiol, we do have that increased visceral adiposity, which again is that level of belly fat, and then the worsening of insulin resistance, so that increases our risk of type 2 diabetes. um and then the high hot, or sorry, the people who have increased levels of hot flashes, that's actually, you know, those vasomotor symptoms are actually tied to increased cardiovascular risk. So brushing off, you know, hot flashes isn't necessarily, you know, like, it's not funny obviously, but someone's actually miserable going through it. But if someone's having severe hot flashes, this is actually tied to you know, increased cardiovascular risk long term. So this needs to be addressed, right? And with the progesterone, that usually will modulate things like fluid retention, body temperature, your ability to sleep. But then if you're having all that fluid retention, you're just going to feel bloated all the time, right? And so so when we start to look at body comp here, this is where we can start to understand, like, okay, well, you know, their visceral adiposity has increased at this level, this is how we can address this, right? Like, obviously, decreasing that insulin resistance and improving insulin sensitivity is a huge aspect of this. And so when we have body comp to back this up, then that helps guide somebody's care, right? Like, does that mean, okay, let's increase your resistance training, we're going to do, you know, HRT, we're going to make these sorts of changes in your diet, or we're going to go up on, you know, protein intake or whatnot. Obviously everybody's different. But that could really be a game changer, because then someone can also track their progress, right? So as they're making some of these changes, if they've started hormone therapy, if they've started medical weight management, they can start to track, like, how are these changes occurring internally. It doesn't just have to be oh, like, my belly fat's better or worse, or my waist circumference. Obviously that's helpful, but this is, we're actually getting real information out of the body comp. And same with testosterone, right? Testosterone in men will support muscle mass, obviously their basal metabolic rate, and it reduces visceral adiposity. But men also have a decrease in testosterone, you know, later in life, so that also increases their visceral adiposity, right? So this is exactly where you can track, like, okay, their muscle mass has dropped, you know, as so and so has transitioned into their 50s, 60s, and beyond. And again, visceral adiposity is increasing, insulin resistance is increasing. So we're seeing these changes on body composition with aging.
Right. Yeah, that's important too, because I think we've been so focused, as a just in general healthcare, we've focused so much on just weight. And so if
Mm-hmm.
someone's weight could be quite stable,
Right.
but as you're saying, muscle mass could be going down, visceral adipose
Yeah.
tissue could be going up. And so that's, both kind of supporting that they're in this transition and
Mm-hmm.
letting you know there are some areas to maybe to work on too.
Absolutely. I mean, I think this is a level of information that we didn't traditionally have, right? And so it's actually really important to understand what is going on from the muscle mass perspective, from the adiposity perspective, and that helps us to target patients' care.
So then say somebody, gets on hormone replacement therapy, whatever, kind of combination, maybe therapy
Mm-hmm.
that is. How do you see then body composition changing? So are these numbers, does it go up quickly? Does it take time? How often are you monitoring?
Yeah, so I think we don't have standards of care around this, right? I think in my practice, I would be checking quarterly, if not every about 6 months, to understand, after starting something like HRT, all the lifestyle modifications that someone might be doing with weight management, especially if they've been on a medication for weight management. How are these changes happening? And I think, again, I think it really helps to guide care, but we don't have standards right now around like, oh, it has to be every 12 weeks or it has to be every 6 months, but I think somewhere around 3 to 6 months, especially in that first year to 2 years, would be something that I would do, just to be able to monitor, like, well, how well is this patient doing, because it also allows you to pivot if needed, if something's not working
Mm-hmm.
for somebody. And so, again, that goes back to like, what does their day-to-day lifestyle look like? Does this mean that, are they developing sarcopenia, which again means loss of muscle? And do we need to really emphasize more resistance training? How can we help these patients with those strategies to increase that? Or is there not a decrease in that visceral adiposity? Well, what's going on, right? Like, what does that day-to-day lifestyle look like, so that we can have that continuity of care and allow the patient to have long-term success?
So have you seen big changes then, like someone say getting on testosterone? Do you see change in muscle mass significantly? I mean, is
Yeah,
that
I think it depends on the patient, but ideally, yes. So I think if they're doing sort of everything perfectly, you should technically be seeing an improvement in their muscle mass, and that's actually really encouraging to the patient too, right? Because
totally?
they're seeing that, okay, all these efforts, even though maybe my weight hasn't necessarily changed by 5 to 10 pounds, oh, all of a sudden my visceral adiposity is here and my muscle mass has gone up, and I think that is really, really important to make sure that people are continuing on that path. But yes, I think ideally, if we're sort of doing everything we're supposed to day to day from a patient standpoint and from like the medical management standpoint from our team, patients should be seeing an improvement in muscle mass. That's the expectation.
Well, it's like everything's against you too. You're getting older, so
Oh, it's
each
so hard.
each
Yeah.
time you check, you're getting older. So these
Right.
curves are kind of aiming downwards.
Right.
If
Right.
someone is also, and maybe you can talk some about that. People taking the GLP-1 medications now.
Mm-hmm.
How that's impacting. Either alongside hormone replacement therapy
Right.
or without. That's clearly going to be changing their
Yeah.
body composition some as well.
Absolutely. And this has been a really big part of our care, especially in the last few years, right? I will say again, a very large portion of my patient population is these women who they come in, and most of my patients are not out eating fast food or processed food, or they're trying their best, right? Like, they're trying to have a very conscientious dietary plan, they're working out, and they just seem like they're hitting like a wall where it's just not budging, right? The number on the scale is not budging, and that can be very discouraging to people, right? It's like, well, I'm doing everything, why isn't it working? Well, it's not your fault, it's your hormones, right? It's the fact that, again, like, you're in potentially perimenopause or menopause, you're battling against your own physiology and you're trying your best to overcome it, but unfortunately your physiology is what it is. So when we combine that HRT with medical weight management, whether that comes from GLP-1s or another weight management agent, that's when we start to see that level of success, right? People feel better, they're sleeping better, they have greater energy to be able to exercise. They're already kind of being mindful of what they're doing day to day, but now they're actually seeing results. But it's not a failure on their part to start on medical therapy, right? Like, this is just to enhance what you're doing. But truthfully, we're treating a deficiency here. And so we're just replacing what you should have had. And again, there's no point just like hitting a wall and feeling miserable and not seeing results. But when we do combine HRT and whether it's GLP, or again, or some of our oral agents, we're seeing good results, right? And people feel like, oh wow, like what I'm doing actually matters, right? And I'm seeing results, and it's not perfect for everybody, right? We have to figure out what works for each patient. But certainly, I would say that this has been a significant part of like my care pathway for patients.
Yeah, it seems like we're coming out of that era of just sort of suffer through and,
Yeah.
it's your fault, deal with it, and
Mm,
coming into an era of, you can maybe thrive a little bit and have, you
exactly.
know, return of, maybe that is in the end, the balance of the hormone levels
Yeah.
along with some of these other
I
things,
mean, I hate to say it this way, but I think if the opposite sex went through this sort of transition, we would have had guidelines around it. We would have had, a therapeutic, like everything done generations ago, right? Like this is just what we see in medical care.
Yeah. Well, I'm glad that we're for my own age group right now. I'm glad
Ah,
that we're in this era and not 20 years ago.
exactly,
Um,
exactly.
yeah.
Yeah, we can actually help, and we have the
Yeah.
evidence to be able to do it.
So I did another, kind of another question that came up that I wanted to, hear some thoughts on is just, how maybe the different medication or sorry, the hormones, how some of the different formulations, like, I know there's been talk, at least for women, and, pellets or gels or like you
Mm,
sort of said, oral and medication, like there's so
right.
much of that out there. Is there some consensus on that, or is that really a patient-centered kind of discussion with your provider?
Yeah, I mean, a bit of both. So typically in the setting of HRT, like I said earlier, topical estradiol is better absorbed than taking it orally, because when you take an oral estradiol, it's going to be broken down by your liver. So that's called, like first pass metabolism. And so that's where it doesn't. We haven't necessarily seen that much effectiveness in oral estradiol treatment, but progesterone doesn't work that way, and that comes in an oral form. But there's
Hmm.
different ways of doing it. This is sort of the estradiol patch and like the oral progesterone that is more so just traditional HRT. But there's people are doing all sorts of things, obviously, and that's where I really recommend working with OBGYN to understand, what are the best options. For some people, it might be an IUD. Some people, it could be even a low dose birth control pill, and so that could take care of it. So it depends on the patient. It depends on where they are sort of in that like cycle of things. Or are you peri? Are you like post menopause? Are you, what are all of your symptoms? So as an endocrinologist, I actually work very closely with our OBGYN colleagues to understand, what might be the best, treatment for this patient. However, things like pellets, like whether it's from an estradiol standpoint or from like testosterone pellets, we actually have not seen great data around pellet usage. So that's probably not something that I would recommend. I think it's also important to understand like bioidentical hormones versus not bioidentical hormones. Typically, bioidentical hormones are not necessarily vetted by the FDA, and so that's also something that we want to be careful about, and kind of take like again like the FDA approved formulation. Different clinicians will have different opinions about this, so I'm not necessarily making a blanket statement. And but that I think at that point it's important to figure out like what's going to work best for somebody. But from an endocrine standpoint, this is where I often do lean on my OBGYN colleagues to if there is something more internal to be placed, like all there's so many different things. And so I'm very willing to like announce where like endocrine cuts off and like OBGYN starts. And that's important,
Yeah,
right? Like I think it's important to make sure
totally.
like this is where we need our colleagues to jump in. And it's also important to understand like if patients haven't felt well on hormones previously, if they have a personal or family history of breast cancer, if they have a history of blood clots, like they might not be good candidates for something like HRT, right? And so, but they're, I wouldn't lose hope though. There's something that could still help mitigate symptoms. So this is exactly where our gynecology teams can be very, very helpful. In addition to, if you have a history of blood clots, working with hematology as well can be very helpful too, to understand like what's safe, what's not. And so it's always like safety first from our end, and then, being as evidence-based as possible.
Yeah, there's so many parallels between sort of what you're talking about and sort of the newer medications
Yeah.
in obesity care too, with
Mm-hmm.
compounding and the FDA approved medication, and
Totally.
really similar advice, I would say, in taking the patient at the center, listening to their
Yeah.
symptoms, listening to what they've tried before, assessing the best available evidence at the time, and sort of working
Yeah.
with a care team that can keep you at the center of their focus.
Absolutely. And that's important. And I think, sometimes when that doesn't happen or there's a breakdown in communication, that's where patients start to feel like, oh, we were dismissed or something like that. And this is 100% a reality in our medical field today, right? I know this very well. And so again, like the more informed the patient, the better, but making sure you're accessing the correct kind of information is also really, really important.
Any recommendations of the best places to go for either patients or providers for in this specialty?
Well, I mean, again, endocrinology, we're at least, well, a certain number of endocrinologists are pretty comfortable with HRT. I would start with the OBGYN though, because I would say women definitely have more of a relationship with their OBGYN a lot of the time, because this is, your annual visit. And so, I would start there. And if you have an established endocrinologist, that's fine too. But a lot of people don't. But most women will probably have an OBGYN. So that's where I would start. And be aware of your symptoms. You could write them down, understand sort of what the timing is. Just certain things trigger various symptoms. So I think coming in with that kind of information is never a bad thing.
And does it feel, just, in your experience, how does body composition feel like it's becoming standard practice? Is it already there? What do we need to do to sort of help that, move the needle forward on that?
I think that it's becoming more standard practice in weight management clinics, but I don't think it's necessarily become standard of care in primary care clinics, OBGYN clinics. And so, unfortunately, our insurance system is very archaic, right? Like we're not able to use body composition measurements to be able to approve medication for patients. And so, unfortunately, from an insurance standpoint, it still always comes down to BMI, which is completely not helpful. But the other part of it is, I think there's also less awareness about body composition in clinical care. And so that's where I think, making sure that we are having these sorts of conversations, that can be very helpful. And I think, even for patients like outside of kind of perimenopause, menopause, people who have heart issues, right? Like maybe you have congestive heart failure and you retain fluid and it's really hard to differentiate, is this weight gain because of water, or is this because of adiposity? What if you have liver disease? There's like a whole host of various medical conditions, renal issues, if you have kidney disease, all these things. Having body composition measurements is a much better measure than just the number on the scale. So I think it's game changing, but I do think it needs to be more widely used.
So for your professional associations, is that ACE, is that ADA, or like where are your people from a professional meeting standpoint?
So for endocrinology, it would be ACE, ADA, Endocrine Society. Those are our big ones. And then we have, American Thyroid Association, but that's like very concentrated towards thyroid health, thyroid cancer, et cetera.
Yeah, I think I need to network with that group a little more because it seems like it's such a natural fit.
Absolutely.
So I think once, like you said, they learn more about the role body count could play, that really would
Exactly.
be a natural
And
tool for them to
I think
offer.
both with actually ACE Endo Society and ADA, they've created their own like obesity sort of tracks
Mhm.
even. And so I think that this is just sort of part of our regular care now, and or it needs to be if it isn't.
Yeah. Well, it's an exciting time for sure.
Mm-hmm.
Well, yeah. Well, thank you so much for this
Yeah.
conversation. I learned a lot as a
Good.
patient and professional, and I really appreciate you taking the time. How do we best stay connected with you for our listeners?
Feel free to follow me on social media. On Instagram, it's Disha Narang MD. And I need to post more than I do, but I am available.
Okay. Well, we'll make sure to post your links and have a great start to
Thank
2026.
you.
And
Happy New
I'm sure that we'll
Year.
see each other at the next meeting.
Absolutely. Thanks for
Okay.
having me.
Thank you.